Dr. Jindal had clearly mentioned that pediatric population receiving ICD therapy is underrepresented in major trials. But many children present with a history of aborted sudden cardiac death. Many of them could have inherited arrhythmia syndromes like long QT syndrome, Brugada's, or short QT or CPVT, with a very high chance of having sudden cardiac death in childhood. And many patients with the children with a congenital heart disease can have arrhythmia as a major component. The challenges associated with the intracardiac Cardioverter defibrillator use in children are unique. Let us see one index case. This 12-year-old girl with a history of recurrent episodes of LOC was diagnosed to have long QT syndrome at the age of 5 years. This child was not going to school due to repeated events. You can see the ECG that clearly shows very long QT, QTC more than 600 milliseconds, extending into the next P, and even having beat-to-beat oscillations in QRS morphology. This patient also had a macroscopic T-wave alternance, and when presented to us, we had admitted for evaluation, and within a few minutes of admission to CCU, because of the emotional stress, this patient had multiple runs of torsides, polymorphic VT with an underlying long QT interval. Had more than 20 episodes in 24 hours. We were really worried, but the parents were not, because they were very used to have these events in the past. So this patient was already on beta blockers, was planned for a cardiac sympathetic denervation, or is this patient a candidate for ICD directly? That is a relevant question. In this talk, I will be discussing mainly on indications for ICD in children, technical challenges in placement of ICD, how to optimally program these cases, and what are the expected long-term outcomes when you place an ICD in a child, whether there are any alternative options in them, whether we can avoid ICD in them. This is a study published from UK. The ICD indications in this group predominantly constituted of two subgroups. One is channelopathy, which accounted for nearly 40 to 50% of them, and another major group, as mentioned by Dr. Jindal, hypertrophic cardiomyopathy, and another group of congenital heart disease. When a child presents with the channelopathy problems or with the tachycardia in a congenital heart disease, which is often related to scar and re-entry, we have certain options even before ICD, like beta blockers, cardiac sympathetic denervation in channelopathy. But hypertrophic cardiomyopathy is a unique substrate. If the patient comes with a ventricular fibrillation aborted SCA, and we have only limited options, and this patient, this subgroup may probably go directly for ICD even before other substrate modification or strategies. But still we need to do risk stratification in them because of the problems associated with ICD at implantation as well as during long-term follow-up. This child has to live for another 50 or 60 years afterwards. So we need to find out the high-risk subgroup and make all possible effort to avoid ICD. Patients with the cardiac arrest who had sustained VT, severe ventricular dysfunction, malignant genomics, and all we should consider in this subgroup. And in patients, as I mentioned, certain subgroups definitely may need ICD. Even in congenital heart disease, either it is childhood or adult congenital heart disease, the arrhythmia risk is not same. You can see some of these patients who had a scar, ventriculotomy, or per se because of the hemodynamic stress, can have very high incidence of arrhythmia, and some of them could result in SCD, but not in children. Most of them develop during a grown-up stage, but it is a fact that approximately a quarter of deaths in adult congenital heart disease occur due to ventricular arrhythmia. We'll take up each point one by one. What are the challenges at implant? You have a device body size mismatch, large device, usually meant for adults, small veins, small ventricular cavity, especially in patients with a hypertrophic cardiomyopathy, need for epicardial placement, and complications in young children like in adults. I mean, similar to adults often, but more complicated by difficult vascular access, need for linear growth with years, narrower vessel lumens with a high risk of thrombosis and fibrosis, which would limit lead revisions or lead extraction later on, and of course, high lead failure rates related to pull and push during the growth, and also due to all the narrower and positioning, all these factors related. This is one of the studies published recently, single center, but over a period of 12 years. You can see only 15 patients had an ICD at a very tender age, less than 3 years. And overall ICD implantation is in young children is quite underrepresented in major trials, and even major centers have limited experience in that. This is our registry, the 22 pacemakers in children less than 28 years of age. But even less than 12 years, we have only very limited cases of ICD. You can see the size of the ICD PG. It's much bigger as compared to, in proportion to the child. And when you have a larger device of an ICD, this is on pacemaker. So you can just imagine how it would look like. And associated congenital defects were seen in almost 40% of our childhood pacemakers. So these cases also, there are multiple limitations related to vascular access, entrance to the cavities, and positioning, and all in patients with a congenital heart disease. With the abnormal anatomy, this pacemaker in a TGA post-sending, putting an ICD in this case would be really difficult. Even pacemaker appears limited. So another case, 22-year-old tricuspid atresia, VSD-PS, post-BDG atrial septostomy, fenestrated lateral tunnel, Fontan failure due to junctional rhythm. We had done a 3D electroanatomical mapping and put a pacemaker there in the lateral tunnel, which is part of the native atrium. It is not extracardiac Fontan. So this patient, if needs an ICD, we have to go for an epicardial route. An intracardiac route will be almost prohibitive due to various reasons. Again, lead failure is a major concern in the childhood ICDs. Transvenous lead failure is more common as the child grows, as in conventional pacemaker in very young age. An endocardial ICD inserted in childhood may need more lead revisions and lead extractions also. And one study published recently had shown nearly 40% of the transvenous leads in adults needed revision versus half of it in adults for a time frame of 15 years. So we may end up using defibrillation coils, arrays, or patches. Conventional one is a defibrillation coil mounted on a transvenous lead coupled to an ICD generator, and the ICD generator is placed in a pre or post spectral pouch or in the abdomen. Other options are subcutaneous ICD coils or arrays, epicardial patches or array, or purely subcutaneous ICD. So epicardial coils placed. Traditionally we used to do epicardial coils or patches in the old time, and now we have specialized subcutaneous ICD. These are the epicardial coils, and the pulse generator is in the abdomen. Can have also a hybrid approach, subcutaneous ICD with an epicardial lead for pacing, but epicardial coils are not readily available in the country. We have short of even bipolar epicardial suture leads in the country. We had St. Jude Microni pacemaker in the past for pediatric age group. That is also not being marketed across the world now. So we have shortage of hardware specifically designed for pediatric age group, and that is true with ICDs too. Then subcutaneous ICD, an entirely subcutaneous sensing and defibrillate ICDs. It does not require an insertion of any leads into the vasculature of the child. You can use the vasculature for subsequent lead implantation when the child reaches adulthood. That is a specific advantage. And it is arguable that it's easier to replace a subcutaneous lead compared to an endocardial lead system. Still, they are large devices. This is entirely subcutaneous ICD generator and coil. In India, it's by Boston. So what are the indications to subcutaneous ICD? Primary prevention of SCD, young patients, of course in child channelopathies, idiopathy. Specifically, they are patients who need shock only rather than ATP, because bradycardia pacing is not a function. So those with indication for anti-bradycardia pacing, you cannot consider this. And indication for CRT, inadequate transcutaneous signals. We look at with this sensing vectors even before, with a conventional way. At least one of them should have in two postures a reliable sensing vector before we select it. And 15% of the candidates as such may not qualify for subcutaneous ICD due to this. To do defibrillation testing at implant or not, adults, it's no longer practiced even in India. But these children are at already general anesthesia, and you can consider DFT. And most of the trials had done DFT in this subgroup. Upper limit of vulnerability or something that would avoid risk of repeated shocks would be an option in them. Sensing vector can be endocardial, epicardial, or subcutaneous sensing leads. And the subcutaneous ICD device select the best of the three sensing vectors as I mentioned, and has got unique arrhythmia detection algorithm based on rate detection and feature extraction. Shocking vector, transvenous devices, if they are used, it's in the conventional way, RV coil to generator. For the devices with a subcutaneous coil, the shock vector is from the anterior cathode to posterior anode with the generator inactive. It's a cold can approach. Generator is not in the circuit. Shock energy is individualized. And subcutaneous ICD delivers a non-programmable shock of 80 joule using an automated vector capable of reversing polarity in the event of failure to cardiovert. Windows, as in adult, and is always individualized based upon the indication. SVT discriminators should be switched on. Complex congenital heart disease like Fontan, if we consider an ICD, it has got special problems. Very high rates. Active kits with normal AV conduction, the rates can be quite high. Drugs can have negative inotropic effects, so often beta blockers or calcium channel blockers are not used. Ablation has many challenges like access, baffle, puncture, disease substrate. Very high degree of lead failures, markedly higher baseline and peak heart rate that needs programming individualized. Rapid growth in the first several years of life can cause system malfunction. Increased rate of inappropriate shocks, at least in the older devices and older series. Long-term ICD programming and management also requires. Outcome-wise, this is a study published recently. You can see there's almost one single center analysis, 195 patients. Extracardiac devices had more appropriate shocks. Obviously, they were more indicated probably. That is why they were put in a younger age. But rate of inappropriate shocks were not different. Lead failure was more prevalent in those who received extracardiac ICD. Even in younger age, you can achieve reasonably good result and with a good outcomes in this, as shown in this study. And coming back to our patient, this patient had history of recurrent LOC, had macroscopic T-wave alternance, multiple episodes of events, and this patient we put on mexiletine. You can see the homogenization of the repolarization within an hour of mexiletine, and this patient QTC has shortened down to 472 milliseconds. And this was, as you can see, it was in 2011. And 11 years down the line, she is a staff nurse right now. It's genotyped LQTS3, 100 milligram with beta blockers. I'm not going into details of this adult congenital heart disease, a special group, and risk stratification is challenging in them. You have multiple issues as already mentioned, and many cases you can consider ablation, like this case, easily inducible on RVOT pacing and entrainment signals RF ablation in the isthmus 3, and after ablation, no inducibility even with a triple extra. So this elegant concept has already been discussed by Professor Joy Thomas. And concluding, ladies and gentlemen, use of ICD in children has specific challenges related to implantation techniques, hardware selection, programming, and long-term outcomes. Meticulous stratification and use of optimal therapeutic approaches may avoid or help to postpone the use of ICD in many children, as shown in both the cases. And subcutaneous ICD may be a reliable and durable alternative to the conventional transvenous counterparts in prevention of SCA in specific subgroup. Thank you all for the patient hearing.